So here I drew a cell, right? And this is probably, would be your ventricular cell. This could be your atrial cell. And these cells, they do not have the inherent ability of automaticity, right? So they do not, right, have this self ability to depolarize. But which specific tissues in our body has the inherent ability of automaticity? Can anyone tell me?
SA node, AV node, and Purkinje fibers.
Right, the SA node, right, the AV node, and the Purkinje. Right, so excellent, right? So these cells, they have the inherent ability to self-depolarize. And if I look at their action potential, right, at this graph, you see how here, when I was drawing this phase 4, the slope is flat, right? But on the SA node, it looks like this. So the slope is not flat. AV node, it's a little bit like this. Slope is a little bit longer. And on the Purkinje, it's even longer. But they all have slope, right? So what I'm saying is this phase 4 is not flat, right? And why, we talked about, right? SA node, the rate was 60 to 100. The AV node was 40 to 60, right? Beats per minute. Purkinje was 20 to 40. Question then becomes, right, why is the SA node the inherent pacemaker as opposed to it being AV node or Purkinje?
The higher slope, it'll cross the threshold faster.
Right, exactly. Excellent, right? So here, let's say if this was your resting state and this was your threshold, right? Same thing here. You could see, right, the slope of the SA node is much more upright, right? Versus, so if I take different colors, so this was your SA, the AV may be like this, right? And then your Purkinje may be like that. So all of them have slope, right? But the slope is much steeper on the SA node. So what it does is it will first be triggered to depolarize. And when the impulse reaches the AV node, right, then it will continue. Why does the AV node does not, all of a sudden fires? Because when this impulse from the SA node, right, reaches the AV node, it's called something as, it causes suppression. It causes suppression of the AV node. So the true name of it would be override suppression. So SA node will override suppress the AV node from firing. However, right, what do you guys see, right, in the setting of, let's say, a third-degree heart block? Third-degree heart block, right, the AV node isn't impacted, is not really firing, right? There's no communication between the atria, right, and the ventricles, right? So let's say there's a cutoff. So if I look at the heart rhythm, right, we see third-degree heart block. What do you notice about the atrial activity compared to the ventricular activity?
Atrial is much faster.
Atrial is much faster, roughly, right? Maybe in this realm, and the ventricles are probably in this realm, right? 20 to 40, and the atrial rate is maybe 60 or 70 or whatever it may be. Why is that? Because the AV node is cut off. There's no communication, right? So the SA node triggers the impulse, right? It gets to the AV node, but it's infarcted, right? Or it's not functional, right? So it's not being conducted to the Purkinje. Purkinje saying, we are the next pacemaker in line, because it's not sensing the SA node response. So it starts to fire, right, at whatever rate, let's say 30, right? So that's why we see this atrioventricular disassociation, right? Because now, because there's a cutoff of the AV node, there's no overdrive suppression from this SA, right? So SA fires, AV is not functional, so there's no overdrive suppression, so Purkinje is the next one to fire. And we see, right, on third-degree heart block, atria may be beating at a rate of 70, ventricles may be beating at a rate of 20 or 30, right? And that's usually how this occurs. So this is the lines that I have here, this is the resting membrane potential, this is the threshold potential, right? And this is the slope. And as I was explaining in that, part of the cardiac lecture, which is worth repeating, when we give our antiarrhythmic medications, right? There is basically the purpose of the antiarrhythmic medication is as follows. We can adjust these parameters to better suit our needs, right? So let me take a different color so you guys can see. So one of the things we can do with antiarrhythmic medications, right? We can increase the threshold potential. So it takes more to fire. Another, so this, let's say this is one. The other thing we can do is we can lower, right, the resting membrane. So this would be 2. The other thing we can do is we can decrease the slope, right, by giving you antiarrhythmic medication. So we can make a slope like this, right? This would be 3. And then the other thing we can do is we can prolong, right, this repolarization phase. So we can do it like this. So this is increasing. So 1, 2, 3, and 4, right? So when we give an antiarrhythmic medication, we could either increase the threshold potential, lower the resting membrane potential, lower the slope here, or increase this repolarization phase, right? And different drugs do so, right? So just to give you an example, right? Your adenosine predominantly works by lowering this resting membrane potential. Also, your parasympathetic stimulation, right, does that exact same thing. Beta blockers do number 3. They will lower the slope. Your sodium channel blockers, and your calcium channel blockers will lower this slope and increase this threshold potential. So they do a combination of this. So sodium channel blockers and calcium channel blockers lower the slope, number 3, and raise the threshold potential. Now you will say, okay, so they do the same thing. When we want to use it, right? But now remember what I told you, right? The SA node, AV node, their depolarization is usually calcium channel dependent, right? So they use calcium in order to depolarize, as opposed to like ventricular cells, they were sodium dependent. So this phase 0 was sodium dependent. So let's say if this was if I saw a VTAC, right, on the monitor, ventricular cell, right, then maybe I want to give them lidocaine, which is a sodium channel blocker. Now, if I saw SVT, right, supraventricular rhythm, maybe the origin is above the ventricles, so maybe it's calcium driven. So maybe I'll want to give them diltiazem as a calcium channel blocker. But the effects of sodium and calcium is similar, right? And then number 4 here, right, we see this increasing the resting, and that's usually done by potassium channel blockers, which medications like amiodarone, Acidosis is, what caused that. That's why we tell you in the setting of prolonged QT interval, you want to be careful with medications that block potassium channels, right, like Acidosis or amiodarone, because they will prolong this phase, number 4. So just to say, right, what's the purpose of all this? The purpose of all this is that when you guys giving your antiarrhythmic medication, right, they block different channels and different rhythms, like that originate in the ventricles as opposed to the atria, right? They have different ions that are predominate depolarization. Is it sodium? Is it calcium? Right? And so we can adjust our medication to the patient's presentation. So this is basically the whole gist of this conversation, right? So your cells that have this automaticity, right? Well, automaticity means ability of a cell to self-depolarize and have this action potential conducted, right? Is the SA node, the AV node, and the Purkinje cells. And then, since we're in this topic, my question is, well, how does atria and ventricles depolarize? They don't have the slope, right? So they also have, if I draw it here, they also have resting state, right? The resting status. And they also have threshold potential. but there's no slope, right? The slope is flat. So how in the world it depolarizes?
They have conductivity.
They have conductivity, and so how? That's very good, right? So they do have conductivity, and how can you elaborate more? How would the impulse propagate?
So when the SI node would fire, it would move, like whatever was near it, an electrical impulse would move through it to the next near one.
So yeah. So remember, we have something known as gap junctions, right? So let's say if this was your SA node, right, and this is the impulse conduction through here, right? In the atria, right, through gap junction, we have atrial cell, right? So through these gap junctions, some of these ions, right, like sodium and calcium, can trickle in through these gap junctions, and the sodium and calcium can trickle in, right? For example, let's say this was the gap junction here from the SA node to the atrial cell, and then sodium, right, or calcium trickles in, and this can raise, right, to this level, to the threshold potential, and then it will fire. So all these cells are connected, right? They're like next to each other in a network with gap junctions, right? And then it goes to the AV node and so forth. So the way this takes place in the heart, right? First, the SA node is the pacemaker, sets the pace. It has the inherent ability to self-depolarize, and then the remainder of the cells, like the atria and so forth, they get depolarized via these gap junctions that propagate ions through them, right? As enough ions come in, they trigger the threshold potential, and then we have the activation, right? The response. Just so that you guys are clear, right? When I was talking about the SA node, right? And we saw this type of impulse there. When I say SA node and AV node are calcium dependent for their depolarization, this is what I mean. So they also have leaky channels, right? So let's say from the outside some sodium comes in, right? And it gets this to the threshold potential. This is the resting membrane potential, right? Maybe this is minus 60 millivolts. This here is, let's say, minus 40 millivolts. So these some leaky channels and ions come in, and the moment the threshold potential is reached, instead of sodium, right, rushing into the cell to depolarize, these cells have calcium that's rushing in. So calcium is what increasing it to this level. And then here, once it reaches to this point, we have the potassium that opens up and potassium starts leaving. Right? So they don't have as much of that downgrading slope where you have the exchange of these ions, which we saw in ventricular cells and atrial cells, right? It will basically go down here. Another reason, right, I guys told you, right, in the setting of hyperkalemia, right, the first drug we give is calcium chloride, right, or calcium gluconate. You guys carry calcium chloride, right? How is in the setting of hyperkalemia giving you calcium as a first drug, and it's because there's a reason it's the first drug. Why do we give you calcium?
Calcium will compete for the potassium channel and blockage.
It will not block the potassium channel. So I'm saying in the setting of hyperkalemia, right, you have high potassium in your blood, right? Maybe a patient missed dialysis, for example, right? And what I'm saying is the first drug you give is calcium chloride, right? How does calcium chloride help me?
Would it act as buffer?
It will not act as buffer.
No.
By the way, this drug is in fact in your formulary, right? You can call, and it says in the setting of hyperkalemia, you can call medical control for calcium chloride. So in the setting of hyperkalemia, you have high amounts of potassium in your bloodstream, right? and the cells is sensing that. So maybe this high potassium outside, it can take your resting membrane potential to, let's say, -50, right? Because it's a positive ion. So now in the setting of hyperkalemia, you have this, and then to trigger the next impulse, it's like that. And then you go into your VTAC, right? Because from -50 to -40 is only 10 millivolt difference, as opposed to before it was 20, right? So when I give you calcium, right, calcium chloride, what I'm actually doing is I'm going to take this threshold potential higher. So even though you still have -50 resting status, right, resting membrane potential in the setting of high potassium, I'm going to give you calcium, and now instead of having -40 threshold, it's now -30 millivolts threshold. So now I restored this gradient. So now we're back into a normal phase, right? So the goal of calcium, when I give you calcium chloride, is to basically take this threshold potential and raise it. I raise it up, I restore this -20 millivolts gradient between these two, right? So less chance of triggering impulses, right? And less chance of them going into ventricular tachycardia. We give calcium to protect the heart, right? So we give calcium to protect the heart first. That's always the first drug to be given. Hopefully that's clear, right? So if they ask
I have
you
a
why,
question.
yeah.
So because they're both positive ions, would it change the concentration gradient? Would that slow the movement of the potassium?
It will not slow the movement of potassium, but it will raise the threshold of the cell, right, inside the cell when the calcium moves inside it, right? Because we know, right, when we have depolarization occurring, calcium is now flowing inside the cell. So if I give you excess amount of calcium, it will be driven into the cell itself. If it gets driven into the cell itself, right, it will raise the threshold. It will raise this higher, right? And when I'm giving you this in the setting of potassium, right, the potassium will still be there in your blood, right? I haven't taken it out. All I done was I raised my threshold, and still, because I did so, I now regain this 20 difference between 50 and 30. Before we had -60 and 40, right? Then when potassium came in, it became -50 and -40. But the moment I give you calcium, I restored this -50 -30. I restored this -20 millivolt difference between the two. So once I restore this, there's less chance of this triggering this action potential as we saw here, right? Now I'm back to this level. Hopefully that's clear, or not really.
Yeah, that makes sense. That because there's more calcium in the cell, that would change the cell culture.
So the whole purpose is I want to raise this threshold potential, so less chance of this impulse coming in, like we saw -50 to right -40, right, from here to here. There's only 10 millivolts difference, and once I give you calcium, I restore this -20. So -20 is more ions needs to come in to get that generation of the impulse. So that's the reason why we give the calcium. Hopefully that helps you guys understand some pharmacology and also electrical activity of the heart. Right. So here the hormones, again, just to go over the ones you are going to be responsible for. We talked about insulin. We talked about the parathyroid hormone in response to control of calcium. We talked about antidiuretic hormone. We're going to get to it a little bit more just in a moment, for control of reabsorption of water in the distal part of your kidneys, distal convoluted tubule. We talked about aldosterone, right, to retain salt and water. And we talked about epinephrine, right, as the mediator, right, and your receptors for that. Now we get to the nephron, right, to the kidney. We have the afferent arterial, where the blood is coming into the kidney, and we have the efferent where it's leaving. This is called the glomerulus. And now as your blood plasma, right, goes through the kidney, it's going to get filtered. Some solids are going to be reabsorbed. The whole purpose of all this, right, is to make urine. We talked about, roughly speaking, your if your cardiac output is 5 liters, we said about 1 liter is going to go in here, right, to the kidney. About 20% of this is going to essentially go forward, right? Actually, we were talking about the makeup of it initially, right? So the makeup of 1 liter, 60% and 40%. 60% was plasma, and 40% was cells, and then 60% of 1 liter is 600 ml, and then out of the 600 ml, another 20% would be about 120 ml, right? That's gonna basically flow through here, and then the remainder, right, as it gets filtered and all that, right? How much ml per minute you making of urine? You guys recall?
1 milliliter. 1
1
milliliter.
ml, right? Yeah, 1 ml. And that comes out, right? We said there was in the 24 hours, times 60, it was I think like 1440 minutes in a day. So roughly speaking, you make about 1.5 liters of urine on a daily basis, right? So now we're going to talk about different hormonal response on the kidney, right? And what happens. So we make about 1.5 liters of urine. So before we get to that, right, let me just go through that. So the important thing about the kidneys, right, in this portion of your thick ascending loop of Henle, we have these receptors, sodium chloride 2 transporters, right? There is a drug called furosemide that blocks these. So if I block these channels, right, more of these channels will be leaking into the urine. So more of these cations will be lost in the urine. So obviously you could see, right, we lose sodium, we will lose water with it. So you have natriuresis or diuresis. You have kaliuria, so loss of potassium along with it, right? And that's when we give you furosemide, when we block. I'm going to say this is the F for furosemide, right? So furosemide blocks this. And we see, right, diuresis, natriuresis, kaliuresis in the urine. The other thing important about the urine, right? So this portion of the nephron, the descending, all right, loop of Henle, you have both release of solutes, so it's water permeable, and solutes can be released. So water permeable, solute permeable. But as you move up, right, through the ascending loop of Henle, thick ascending loop of Henle, it's no longer water permeable. So all you can do is basically release your solutes, right? And by the way, solutes concentration increases as you move down these, the gradients, right? As you make your way down here, right? The concentration may be 1200 milliosmoles. So this part of the nephron is water permeable. This part is not water permeable, and this part is only permeable when you have ADH acting on it, antidiuretic hormone. So antidiuretic hormone will cause aquaporins to appear, right, on distal tubules here, and they will reabsorb, will pull water once ADH is there. We call it ADH, antidiuretic hormone. So you have less diuresis occurring. When do you want this to occur? When you have low blood pressure, right, or in a setting of shock. Where does it come from, right? Comes from your posterior pituitary gland specifically. We talked about that. It's going to create these aquaporins to reabsorb water. Water is reabsorbed, maybe your blood pressure will be increased, right? So this was different components of your kidney. And let me just show you, right, once more, once we have the ADH. So this is where ADH functions. Without the ADH, right, it's not going to create aquaporins. So this then becomes water impermeable. So the distal convoluted tubule is only permeable when you have ADH present, right? Otherwise, it's water impermeable. Now, let's say you have no ADH, or your body's not making ADH from the posterior pituitary, or right, it cannot bind on the kidneys for whatever reason, right? So the ones we call, right, for the posterior pituitary, and the ones we call for kidneys have two different names, right? This could be nephrogenic, right? And if it comes from your brain, right, from the cranium, right, neurogenic. So neurogenic and nephrogenic. And if you have lack of ADH, you have something known as, does anyone know? What do we call that condition? You're either not making ADH or ADH cannot bind on this nephron. Helmi, you want to say something? Your microphone is muted. Anyone know?
Diabetes insipidus.
Diabetes insipidus, excellent, right? So Brian, 100%, right? So you have neurogenic, you don't make ADH, or this distal part of your convoluted tubule is not functional. We call it nephrogenic, diabetes insipidus. So when you have diabetes insipidus, are you passing concentrated urine or dilute urine? Dilute urine, excellent, right? So you're passing dilute urine, right? Because either you're not making antidiuretic hormone, or the receptors here are not functional. So very good, excellent. So we talked about that. This here, right, is your renin, angiotensin, aldosterone system, or sometimes it's called axis, right? So at this point, you guys should be masters of this. I think I went over through this like ad nauseum, but we'll do a quick overview, right? So when the system is activated, this is not your, seconds to minutes. This is your hours to days. So this is a long-term response. What actually happens here, right? Your liver is always producing something known as angiotensinogen. Whenever you see GEN ending, this is usually a zymogen. This is an inactive protein. So your liver always makes this protein. It's always in your circulation. Now, in a setting of low blood pressure, right, or in the setting of shock, your kidneys are sensing, right, drop in pressure. You have these juxtaglomerular operators, which are made of pulcescent cells, which are baroreceptors, and you have macula densa, which are chemoreceptors. They sense low sodium status. How do they do that, right? You could imagine, right? You have low blood pressure, blood flow through the kidneys is moving very slow. If the blood flow is moving through the kidneys very slow, I can extract more sodium from it. If I extract more sodium from it, the moment it reaches macula densa, it says, okay, it's low sodium, so I'm going to release renin. Same way, if the blood is moving slow, the pressure is low, right? Renin is going to be released. Also, sympathetic stimulation in the setting of shock will stimulate beta-1 receptors on the kidneys. The kidneys have beta-1 receptors, and is going to dump more renin into your circulatory system. So more renin comes into your circulatory system. The moment it combines with angiotensinogen, it's going to activate it. It's going to activate it into angiotensin 1. And then as angiotensin 1 passes through the lungs, specifically the endothelial cells of your pulmonary capillaries, right? The endothelial lining of the pulmonary capillaries, they have this enzyme called angiotensin converting enzyme, ACE. And the moment this angiotensin 1 passes through the lungs, ACE converts this into angiotensin 2. Angiotensin 2 is very, very potent vasoconstrictor, right? So it's going to work on angiotensin receptors. It's going to cause vasoconstriction, but it has other effects too, right? One effect, it will work on the hypothalamus. It will increase thirst, and it will release this AVP, right? Arginine vasopressin, right? I was telling you, arginine vasopressin, same thing as antidiuretic hormone, right? Or vasopressin. So vasopressin working on the kidneys is going to retain more water, creating aquaporins. Angiotensin 2 will work on the adrenal cortex, specifically, right? We were talking about GFR. Zona glomerulosa is going to secrete aldosterone. right? Aldosterone role is retention of salt and water. So aldosterone is going to work on the principal cell of the nephron, right? And what it will do is will basically proliferate these sodium channels, so that sodium that's coming in, trickling in into that part is going to reabsorb that sodium. So whatever sodium is reabsorbed, water follows with it. So sodium reabsorption, right? And it will reabsorb salt and water with it. And hopefully all these effects will increase your blood pressure, right, in the setting of shock. However, we can see, right, if you have someone like with congestive heart failure who was, let's say, admitted to the hospital because they had a massive heart attack and they were in cardiogenic shock, they get discharged, right, their blood pressure is low, the system is going to be working days, right, weeks, months on end, and will start to produce this angiotensin 2 and start to elevate your blood pressure. Angiotensin 2 is also very potent cardiac remodeling agent. So not like good cardiac remodeling, but pathological cardiac remodeling. So we see that hypertrophy developing, right? And all these problems starting to occur, right? So this is what we notice. Now, what drugs can we use to, work on the system that you guys are familiar with? Can you give me some examples or classes of drugs that we use to, or patients use to block certain things in the system?
ACE inhibitor.
ACE inhibitor, right? So ACE inhibitor is going to work on this ACE enzyme, right? And examples of the drugs that end in pril. So you captopril and enalapril, right? All the pril drugs, it will block this enzyme so that you are not making angiotensin 2, right? Another example could be ARB, angiotensin receptor blockers, right? ARB. So like losartan, cardisartan, and they work specifically on angiotensin receptor. So they will block the receptor. So let's say this was the receptor where angiotensin 2 was binding, right? This drug will come here and will not allow the angiotensin 2 from binding. So this is another method of doing that. We also have this medication called spironolactone. It blocks aldosterone. Aldosterone role, right, was salt and water retention. So we have spironolactone that works there to block the aldosterone. So these are some of the targets of the drugs, right, that will block the system. And those drugs are used, you'll see them used predominantly in patients who have high blood pressure or who have congestive heart failure, right? Another role, right, lisinopril is also going to stop this pathological cardiac remodeling from the angiotensin 2. So it's good for those patients as well. By the way, what's more potent vasoconstrictor, epinephrine or angiotensin 2?
Angiotensin 2.
Angiotensin 2, right? Angiotensin 2 is way more potent a vasoconstrictor, right? And it also exerts all these other effects with aldosterone, right, and vasopressin. So the effect is magnified greatly. Any questions about renin, angiotensin aldosterone system?
In the square with the kidneys, it says JGA. What is that?
This stands for juxtaglomerular apparatus. These are the cells, right, that are made up of Pulchissin and macula densa. The juxtaglomerular apparatus. They're the ones that secrete renin, right? Sense low blood pressure and low sodium.
Got it. Thanks.
Yep. Anything else? Okay. So, and I have videos. If you look at the renal chapter, if you want like more in depth, we go through this in great detail, right? So yeah. So this is your juxtaglomerular apparatus complex, right? And it coordinates basically releasing renin through here. And it makes sense, right, why it's located here, because it has to sense both the pressure that's coming in, the blood flow that's coming in, and also the content, right, of the filtrate that's coming in. So does it have sodium? Is the sodium low, right? How fast is the flow? faster the flow, right? Higher pressure, low flow, low pressure. So this is just a close-up view of this. I think we went over through this quite well. Talked about role of your furosemide, talked about ADH, right? And the other part of the kidney, right, is the acid-base balance, right? So the kidneys control pH balance, right? Normal blood pH 735, 745. If you're below this number, you're acidotic. You're above this number, you're alkalotic. How does it do it, right? The formula is still the same. CO2 plus H2O is going to make carbonic acid. And this is going to dissociate into hydrogen ions and bicarbonate, right? So this is the formula. This here is released by the respiratory system. This here is modulated by the renal system. So if you're acidotic, you have low pH, right? Let's say 7.2, right? You're in acidosis. How does the kidney gonna help you, right? Over time, it will try to get rid of hydrogen ions in the urine, and it will reabsorb the bicarbonate into the interstitium. So this can then further grab more hydrogen ions and restore your pH balance back into order, right? 735, 745, right? And when we want to get rid of, right, acid, we basically want to drive the formula in this direction, dissociate carbonic acid to get rid of this in the lungs, right? And get rid of this in the urine. And you want to store this, right, in the interstitium. So basically, this is how the kidney works. Right, so here they give you the same formula, and they show you, right, there's a disturbance, and how is the kidney going to correct it, right? So, so let me just get you there so you guys can see, and then we'll go back, right? So as I was explaining to you here, they show you, right, renal response to acidosis. So the goal of the kidney is to secrete hydrogen ions. So you get rid of this in the urine, right? So ions are being removed, and you have reabsorption of bicarbonate, right? So you move the formula towards this end, and then the excess of CO2 is get rid of the lungs, right? It's the compensatory response. So this is when you have high acidosis. When you alkalosis, is the opposite, right? So the kidney will secrete bicarb in the urine, and it will retain hydrogen ions. And the formula is basically moving this way. You do not want to get rid of CO2, right? Because you are in alkalosis, right? Alkalotic state. So this is what the kidney does. And then here, this chart basically just shows you examples of different conditions. The one we're focusing here for the kidney aspect is the metabolic side of it, right? So acidosis, alkalosis, some of the examples they give you, right? Metabolic acidosis. So I'll show you here, right? Renal failure, ketoacidosis, right? With diabetes, lactic acidosis. By the way, if you give high amounts of normal saline, right? I was showing you pictures, right? There was low pH, like 5.5. You're going to cause what's known as hyperchlorimic acidosis. So you drive this person into acidosis if you give too much of it, right? And the alkalosis, the examples they give you is severe vomiting, right? Loss of hydrogen ions, right? Or you give, too much of the bicarbonate therapy, or people can be taking antacids, right? And they can go into alkalotic state. Usually in a setting of shock, right, we see quite often this metabolic acidosis. In a setting of diabetes, right, how do we reverse this? We give them insulin. So insulin is not to drive sugar in the cells, it's to stop the ketoacidosis, right? Stop the ketones from forming. Any questions about this? All right. So hopefully that's clear. And then right in the hospital, I don't know if you were in ICU, the PA or a doctor, they will draw your arterial blood gases, and then they will look, right, what is your pH, what is your PCO2, right, what's your bicarbonate status, right? So they will look at these levels, pH, PCO2, right? So they will look, right, what is the status here? And this will basically determine, right, are you in metabolic acidosis? Are you in metabolic alkalosis? Do you have any compensatory response to that with like respiratory compensation? So then we look for that. This can then dictate therapy like ventilator adjustments, medications adjustments, and so forth. And these are done routinely, right? Some of you guys, if you end up working flight EMS or HEMS, right? You could carry cartridges and you could do this on the spot, right? You could check someone's blood glucose, arterial blood gases. And they carry specific instruments to do so. But that's what we basically look at, right? When we take their arterial blood. It's basically to look at these disturbances. All right. So this was something about the pH. Okay, so this here concludes the review of all the chapters.